Hello, and welcome to Common Health from the Virginia Community Healthcare Association, or VCHA, or what we're also known as is VCHA. I'm Tracy Douglas, VCHA's Chief Executive Officer. On Common Health, we're amplifying the voices of community health, both those who give care and those who need it. Hello, audience of Common Health. I am so glad we are here today to speak to you and bring you again a fantastic story coming out of the Commonwealth of Virginia. More importantly, coming from one of the federally qualified health centers here in the Commonwealth. We've got two fantastic women that have joined us. One actually works at one of the what we call FQHC's audience, as you know, and that is Meagan Arthur. She's the Director of Nursing and Quality Improvement and Patient Safety at the Community Health Center of the New River Valley. And then we have Dr. Jamie Zoellner, who is the Associate Professor over at the University of Virginia. And I believe, Dr. Zoellner, that you're a registered dietitian as well?
That's correct.
Awesome. Well, although we're going to talk about colorectal cancer and screening, I'd love to just touch a little bit on what does a registered dietitian do. But before we get there, audience, as you know, the whole reason why we do this, why we bring you Common Health, is so that we can really bring you real stories, right, from the people coming out of Virginia that are treated at at our federally qualified health centers, but also from individuals that represent partnerships that our federally qualified health centers have here in the Commonwealth, as well as the employees, right? And this is one of the reasons why we have Meagan with us, joining us today. That being said, Dr. Zoellner, should I call you Dr. Zoellner or should I call you Jamie? You tell me.
You should call me Jamie.
Awesome. All right, Jamie, thank you. Talk to me about what a registered dietitian does.
Okay, well, we think and care deeply about what people are eating and their access to food and how the environment shapes some of their food choices. And so registered dietitians sort of can span a lot of different places of employment. Most historically, you think of them working in a clinical setting, providing medical nutrition therapy to patients, inpatients, but dietitians actually work in all different types of settings. I come also from a public health background, and so I apply my skills to nutrition sort of at the community health level. So, I kind of stumbled into this project related to colorectal cancer screening, but we also know that that nutrition and obesity is actually one of the largest risk factors for the development of colorectal cancer. And so even though we're going to be talking about screening for colorectal cancer today, I've actually been able to apply a lot of my interest around sugary beverages and dietary quality and how that is also influencing some of what we see happening across the Commonwealth in terms of the development of colorectal cancer, because we definitely see hotspots in certain areas in our state, which also parallel some of what we're seeing in terms of compromised diet quality and obesity.
Great. Awesome. It's interesting, Jamie, as you were sharing about your background and training, Meagan, I was thinking, one of the things that I know that federally qualified health centers focus on, community health centers focus on, not just here in the Commonwealth, but in other states as well, is social determinants of health, right, Meagan? And so, one of the things that is really important to us, and audience, for those of you that don't know what social determinants of health are, those are factors outside of your body. Let's look at it that way, right? As a way to kind of explain this. So there are many factors within our body and our genetics that impact our health. And interestingly, we here in community health center world, we have to focus on things like social determinants of health. And those are things outside of our body that still could impact our health, right? And one of those things is access to food, right? Mm-hmm. And Jamie spoke about that, Meagan, and I know that at your health center, those are some of the things that you do focus on because, you know, we see many different populations within our health center that don't have access to good, you know, to food, or the food that they do have access to is not good for them, high in sugar or high in fat, like Jamie referred to, right? And so, you know, Jamie, you know, I think it would be worth maybe bringing you back and having some conversation around how, you know, food is really a component that we like to focus on here in community health centers as it pertains to good health care, right? But we are here, audience, to talk about colorectal cancer screening. And I have to say, ladies, I was watching a news program this morning. I don't know if you all saw it, but one of the news programs, national news programs, had two actors on there that basically were being followed for their colonoscopy, leading up to it, what they had to do to get ready for it, right? Have their colonoscopy and then get the results of their colonoscopy, and come to find out these two actors, actually one, there was a polyp, and the other one, there were 3 polyps that they found. And luckily they found them right in enough time that they could be tied off and taken care of in hopes that there would not be any future cancer. So colorectal cancer screening, Meagan, you know, I understand that you all applied for a grant.
We did.
You all were able to receive the award. Awesome. And the whole purpose of it was to help focus on, in your population at your health center, focus on patients that you could increase, right, your cancer screening rates, right? Talk to us about why you felt going through this for this grant was going to be impactful in what you were trying to achieve over there at your health center.
Well, if I may, I would like to say, kind of generally speaking, about colorectal cancer screening, but then I would actually like to punt that over to Jamie, since she is the person that spearheaded this grant application and was also involved in the QI project that was done back in 2019 prior to my arrival. And so she's got the historical background with that. But, you know, from a colorectal cancer screening perspective, we know that we have major barriers that we have to kind of break through. One of those is kind of just a general stigma around colorectal cancer screening, and also a fear. I think people are fearful. They don't want to have to get a colonoscopy. They don't want to have to take time off from work to prepare for a colonoscopy. You know, and the good news is that we have options now. We have other ways that we can adequately screen patients for colorectal cancer screening or for colorectal cancer that's not a colonoscopy, you know. And so things are looking up in the world of colorectal cancer screening because we have options. 20 years ago, the only option was a colonoscopy, but that's really not the case now. You know, we also know that we have to provide a lot of education about the importance of colorectal cancer screening. I think a lot of people, you know, in our region, in our state, in our country, you know, we have this attitude about, you know, not really focusing on prevention, but only focusing on the problem once it arrives. Yeah. And so there's not as much value, I think, for people to participate in screenings. It's more of a reactive approach as opposed to a preventative approach. And so one thing that we're doing here at the Community Health Center is we're really trying to shift the focus, shift the culture around cancer screenings, generally speaking. So that's kind of where we're at. And so I'd like to kind of turn it over to Jamie now so she can give you a little bit more of the historical background with the grant and also with the first QI project since she spearheaded all of that.
Jamie.
Sure. Well, maybe it would help for me just to provide a little bit of context on what we know about colorectal cancer screening sort of at the national level and then what we see happening in some of our FQHCs, because I think this sets up a pretty compelling story and is really kind of the backdrop and the context for why and how this partnership was launched. But we know that the national level, the target is to have 80% of all age eligible individuals screened for colorectal cancer screening. Just in the past, or screened for colorectal, just in the past few years, that age criteria used to be 50 and now it's 45 years of age. We've seen a lot of early onset of colorectal cancer and some of that has been in the news. So national benchmark is 80%. What we know is that currently about 67% of age eligible individuals are screened for colorectal cancer. That's nationwide. However, when we start to drill down a little bit deeper and think about populations who are accessing services through Meagan's organizations and other FQHCs, that proportion begins to drop dramatically. It's not the fault of these systems. It's just, lack of resources, lack of awareness, trying to prioritize cancer screening or colorectal cancer screening over something else. And so when we first began to work with CHC of the New River Valley, we recognized that their proportion of individuals being screened was under 40%. And so we knew that we had something to work on. And so we first came together kind of over that. I don't want to call it a simple statistic because it's not. I mean, once you start to dig in and really try to understand the reasons behind and the potential solutions contributing to that, it opens up a Pandora's box of things to be thinking about, not only from a clinic workflow perspective, but also from a patient education perspective as well. And so, we were fortunate enough back in 2019, Meagan alluded to, we got a small grant through the I Thrive CTSA program. That's a collaboration with UVA and Virginia Tech and Carilion. But we got a community scholars grant and was able to launch a small 1 year. Well, it ended up being over 1 year because we were launching it during COVID, but it ended up being about 2 years. But we did a quality improvement project within CHC and really saw about a 17 or 18% increase just over this 1 year project that we did on a relatively small budget. And so when this next funding opportunity came with the Jeffries Trust Foundation, they were really wanting system level approaches, and shining a light on some of the health equity issues. And so this was just such a natural next step for us. And so now we have a 3-year project. We have more money. One of the most important things, and Meagan can speak to this a little bit more, is that with this new funding, we're actually going to have money to hire a cancer screening navigator that's employed by CHC of the New River Valley. And although cancer screening navigation is a known evidence-based strategy to improve cancer screening rates, period, a lot of these FQHCs don't have the resources to employ someone who's laser focused on cancer screening, or in our context, colorectal cancer. And so we're really going to be building from some of the other evidence-based cancer screening navigation programs and try to implement that within CHC, the New River Valley. I mean, we have an ambitious goal. Like, our goal over the next 3 years is to try to get them to that 80% mark. And
awesome.
Yeah.
Awesome. And you know what? It is ambitious, but I always sit there and I tell people, um, there's it is always good, right, to go for that ambition. To me, at the end of the day, the services that are provided out of community health centers, our goal is to keep our communities healthy, and we know it's an uphill battle. But at the end of the day, that is what our mission is, right? And it is an ambition. It's very ambitious, but it is our ambition when we work in this industry. And so, Meagan, talk to me and our audience about what this navigator. First of all, how are you looking at using this navigator, right? You know what the population is, right, that you serve. What are you going to do with this navigator? How are you going to use it, and how are you going to get this individual to be able to take on the challenges that you work with every day in the community health center?
Well, those are some great questions. You kind of hit the nail on the head. It's really going to take a very special person. It's going to take somebody who's very passionate, I think, about education, working with providers, working with patients, working with clinical staff, and also networking within the state and other groups, other cancer screening navigators. We have a position posted. We're actively interviewing and recruiting for this role. And, I really kind of see this person as an extension of what we already are doing from a care coordination standpoint. We have a phenomenal care coordination team. We are tracking colorectal cancer screening. We're tracking mammograms. We're tracking pap smears. We're tracking a lot of things, getting patients scheduled, identifying those patients who are not compliant, right? So let's say that they are due for a screening and they haven't had it. Our care coordinators are picking up the phone, calling this person, trying to identify barriers that might be preventing them from getting said screening and helping them to get scheduled. Well, and sometimes that's even an issue with just transportation,
Right.
Or maybe some additional education that they need over the phone or with a nurse visit. So I think our cancer screening navigator will be able to start from there and kind of build a larger program based solely on cancer screening efforts. We're going to start with colorectal cancer screening for this grant. Mm-hmm. Long term, we see this person focused on all cancer screenings, but for the purposes of this grant, we'll start with colorectal cancer. So I think the first thing that this person will need to do and be a big part of is doing a needs assessment, within the CHC, and identifying, what we're currently doing, what we want to do, and how we're going to get from point A to point B. So I think that that's going to be the very first part of this person's role. I think there is, I think this position is fluid and flexible, and, we have specific objectives that we want to meet for our milestones. But then I think we also have to allow, and we encourage that creativity, that personal approach that someone with this expertise that we so desperately want is going to come in with. Right. And they might be able to show us and teach us, hey, this is how we've done this before in previous places, or this is what research shows. So we're going to want this person to, be actively involved in research, education, and knowing best practice and what is taking place on a local, a regional, a state, and a nationwide level as far as colorectal cancer screening is concerned.
Jamie, is there something that you can add to that too? How do you envision this particular position in this partnership that you all have with CHC of New River Valley?
Yeah, I mean, Meagan did such a nice summary as she was talking. I'm like, she's nailing it. But I just want to echo everything Meagan said. I mean, I think, what we're oftentimes there can sometimes be a disconnect in what we see happening in the literature. Like there is so much published on how do we increase colorectal cancer screening, not just at the national level, but even very specifically within rural underserved communities and very specifically within FQHCs. And so, Meagan and her team, they're busy clinicians. They don't have time often to take a step back and say, let me appraise this literature and let me figure out how we can apply this literature within our context. And I think this grant, this Cancer Navigator, is really going to allow us the opportunity to do that. And I think the partnership between, UVA as researchers and as outreach and engagement staff paired with the system, it's just a dream team approach, right? Because you have both the internal stakeholders and then, you have those of us who do have the time and whose job it is to be up on the literature and know sort of what are best practices in other similar organizations and similar FQHCs.
I loved the term that you used, Jamie, dream team approach. Yes. Because I say this every time about community health centers. The individuals that are in those health centers really are a dream team. And when they get to partner with an organization, a health system like yours, right, Jamie? That just really enhances, right, the meaning that we attribute to that dream team approach. And we have to have that approach, right, Meagan, when
absolutely
working in a community health center. One of the things, as you all were talking about how you envision this particular position and who that person would have to be, right? I almost feel like that person, and I don't know, it's just, remember, this is about real people and real conversations, right? Those are the people that we see in our health centers. I almost feel like that person would have to come out of the community that you serve, right? Because they're the ones who know, right, their community. They're the ones who kind of think the way that our patients think, right, Meagan?
Absolutely.
And so with that, I think that they would be the ones who would be more successful in being able to talk and have dialogue with the folks in the community to help get them to understand the importance of that Jamie spoke about with regards to the screening, right? Why you should do it and why you should be focusing on this and that. But coming out of a very challenging couple of years for healthcare workers in our community health centers, there's been a lot of animosity towards healthcare, right? No fault of our own. It's just what existed. And how do you think you're going to be able to overcome that? Because now I think the level of distrust is somewhat heightened. There was already distrust, right? Yeah. But now we've really got a heightened level of distrust with healthcare, the healthcare industry. Meagan, how do you see us being able to work through that?
Yeah, I mean, you make a really great point. Whoever we end up hiring our cancer screening navigator, they have to be able to connect on a personal level with every single one of the patients that walks in the store. We have to meet our patients where they are in life. And, we have patients of all ages. We have patients of varying backgrounds, varying education levels. We have to be able to adapt and meet each one of those people where they are. And so it will take somebody who, like you said, has an understanding of the local culture, the statewide culture, towards anything in life, whether it's, cancer screening or religion or local politics. I mean, you have to be able to understand people on multiple levels. And so, I think with that, having to be able to meet people where they are. And then, as you mentioned, this distrust in the medical community. People are suspicious of things that are now suggested, as far as screenings, because, and, not to go down the rabbit hole, but I think we have to allow for the time for the education. Mm-hmm. And we have to not make assumptions about why someone feels the way they feel. We have to be able to vet those concerns and provide the education, and also have that patient be a partner in their own healthcare. Mm-hmm. We can't just recommend a screening and say, this is what you need because you're 60 and you need to have it. We have to understand why someone doesn't want to have it. And we have to be able to have that conversation and see where we can meet in the middle. And, if a patient doesn't want to have this option, they might be willing to do this option. And this option is better than zero options. So I think it's definitely multifactorial in how we have to approach this. But I am confident that we can find the right person who will be able to do all of that.
Mm-hmm. Yeah, Jamie, you come from a large health system, right? I'm curious, as I listen to Meagan, right? I'm curious as to why UVA feels that you guys can be ambitious, right? To get to that 80% with a partnership with this community health center.
Yeah, that's such a great question. And, I always like to describe my role as I have a foot in both worlds. I'm absolutely employed by UVA Cancer Center, but I live in Southwest Virginia. My office is, a half a mile from Meagan's office. So I run a satellite office. We're very focused on rural health and working with FQHCs. And so, I think circling back to and just maybe putting a little bit of a plug, about the dream team. Meagan is one piece of the picture of the dream team, right. But we also have, we have leadership. Michelle Bronze is really the PI of this grant that we're about to roll out. She's the CEO at CHC, the New River Valley. Dr. Roberts, the Chief Medical Officer, has been very involved and very supportive of what we've done. In our previous project, I can re-emphasize everything Meagan said about the care coordination team. We were able to execute that project during COVID because there were individuals involved, not just from leadership or not just the clinic staff, but really sort of this vertical involvement of individuals across the system. And then, I guess the other side of that is, UVA Cancer Center is now designated as a comprehensive cancer center. That means that we are interested in basic and clinical science, absolutely, as it relates to cancer diagnosis and treatment. But we also have a real emphasis on cancer control and population health. And I think this is just such a good example of, cancer is not just about diagnosis and treatment. It's about prevention. It's about early detection. It spans all the way the spectrum through long-term survivorship. And so there's a group of us at UVA who are very focused on cancer prevention and population health. I'm an N of one, but we have a team of about 30 or 40 of us who are very interested in addressing issues like these. This is a project highlighting CHC of the New River Valley, but we also have partnerships with several other FQHCs across the Commonwealth doing some similar projects. So I think it's that sort of shared vision and shared leadership is why I feel confident that we're going to, be able to reach that 80% and really serve as a model for other FQHCs across the Commonwealth and beyond.
So, can I add something on to that?
Please, Meagan.
I was going to say too, we are beyond lucky to have Jamie and her team as a resource here. And, prior to my arrival, I know the project that's been done, but then I also, in monitoring our UDS numbers, see the continued impact of that first project. And, we have a goal of 80%, and we know that it's lofty, maybe for people to consider 80%, but I feel confident that we're going to get there because of the partnership that we have with Jamie and her team and with UVA and with the impact of the first project. When we look at our UDS numbers, compared to other FQHCs in the state, we're really doing fairly well. I mean, when you look at other people who are low to mid 40%, we're sitting at 53%. And so Jamie mentioned, prior to that project, we were, I don't know the exact percentage.
You were around 31% when we started, and we ended at 47, and now you've already crept up.
Yes.
You're continuing to see that creep up. So
so that impact is so far reaching, and I think that is just a perfect example of how this partnership that Jamie has with us and the other partnerships that she and UVA have with other FQHCs continues to be so meaningful for the staff and the patients at the FQHCs where they are served. So, I mean, we're going to make it to 80%. We will.
Hey, I have no doubt that you will. I mean, just talking to the two of you and with the other individuals you talked about as part of your dream team, I definitely think I know you'll get there. For the purposes of our audience, ladies, you, Meagan, referred to UDS. I don't think many in our audience knows what that is. And then, Jamie, you talked about percentages. Can you just real briefly, Meagan, talk about what is UDS in the community health center world? And then, Jamie, can you just talk a little bit about what these percentages mean?
Mm-hmm.
Yeah. So, as an FQHC, we are constantly tracking certain measures within the center that we report to the federal government. And, those measures are tracked very closely with multiple team members, and our providers and our clinical staff are all very involved in kind of seeing where those numbers stand. And it's kind of a benchmark for us to see how well we're doing and what we need to improve. Some of the things that we are being assessed on from the government or from HRSA is, one of them is colorectal cancer screening. Another one is our mammogram screen, our mammogram rate. How many patients that are eligible and should get a mammogram, how many of them get one? How many patients are due for a colonoscopy or a FIT test or, whatever form of colorectal cancer screening they're due for, how many of them actually end up getting that? We look at other things like depression screenings. Are we screening every patient that is appropriate that walks in our door for depression? And if they screen positive, are we appropriately managing that? So those are the kind of things that we are constantly reviewing on a daily, on a weekly, on a monthly basis. And it kind of helps us keep in check with our goals. We set yearly goals for ourselves for these measures. And those goals might change from year to year depending on what we report. But when we get our scorecard or our report card, if you will, we can see where we compare to other FQHCs within the state and then also nationwide. So we know the work that we're doing and how that compares, generally speaking.
So
and
it's almost like, Meagan, I'm sorry to cut you off, but it's almost like you're holding yourself accountable to your outcomes, right?
Yes.
So you're constantly looking at your clinical measures, right?
Yes.
And if you're seeing things that just are not trending in the way that you all want, because you've established some benchmarks for yourself, right? If you're not getting to those benchmarks, you're holding yourself accountable to why you're not getting to those benchmarks, right?
Absolutely. And we, the goals that we set are not arbitrary by any means. We are very intentional about the goal percentage that we set for every single measure. We have a team and a committee that sits down and reviews this multiple times throughout the year. we look at Healthy People 2020 and Healthy People 2030 goals to help us kind of set those goals for ourselves. We also have a data scientist that is also going to be working with us very closely with this grant that we just were awarded. And she's able to run that data for us. And, like you mentioned, there have been a couple measures that we know we're doing what we're supposed to be doing, but maybe it was just something that it was the way it wasn't documented. There wasn't a box checked within our EMR. And so, she is able to kind of help us on the back end identify how we need to rectify that to accurately reflect the work that we know we're doing.
And Jamie, so with that, talk about these percentages that you all, again, about holding ourselves accountable, right? What do those percentages mean?
Yeah. So, the great thing, Meagan just explained the UDS numbers. For me as a researcher, all of that data is publicly available, right? I can go on HRSA's website and download all of that data, and I can kind of sit in my office and say, hey, these look like there are some regions across our state or within UVA's catchment area that are low on certain screening criteria. And so, those percentages are available. However, often we don't know the why behind them, right? Like we can see that they're low, but not until we go within the healthcare system and start having conversations like we've had with CHC, do we really start to sort of unpack the why. I think another element of the conversation is that we also sometimes see, what we're able to pull off publicly is just 1%. We're able to pull 30% or 50%. What we can't pull publicly is, do non-English speakers, are they at a different rate? Do we have certain race or ethnicities that are at a different rate? Do we have a certain age criteria? So it can also allow us to have some targeted strategies, which is one of the things that we plan to do with this grant. It's one thing to move the entire percentage forward, which is a good thing, but it's also to do that in an equitable way, such that across all race ethnicities, across all age ranges, that we have some similar goals in mind. So, typically with these UDS numbers, low means bad and high means good. And so we're trying to get these percentages higher and higher and higher. So
awesome. Well, I'll tell you, and we'll be talking about this hopefully on a future show, but here in the Commonwealth of Virginia, Meagan, you may be aware of this, talking about getting to the why, although you guys are going to be focusing on colorectal cancer screening, then it's going to be, okay, now you've gotten them screened and they have a positive result, right? Then what do we do, right? But then how do we get behind that data, right, that you were referring to, Jamie, during the preventative state? And one of the nice things that's happening here in the Commonwealth is one of the big things I think we need to do a little bit more justice on for our communities is let's all of us, right? You guys are an example of this dream team approach. You've got two healthcare systems working together. But wouldn't it be amazing if we got multiple health systems and diagnostic referring organizations a part of it? So we have what we call a data warehouse that's gone up, and actually New River Valley is a part of that. And so Jamie, talking about getting to the why, we're going to be actually able to help New River Valley and a bunch of other community health centers, right, to be able to get behind the numbers. And we're very excited about that. And the reason why is because the Michelle Bronze, the CEO of the health center, and other CEOs, as well as the Meagans out there and the chief medical officers and others, said, yeah, we've got all these numbers. Yeah, we can put things in place, but we got to get to the behind, right? The why. And there's more to the data. There's more to the numbers, Jamie. And I think this is a great start for you guys. And then we can help the health centers as well as yourself kind of get behind the numbers as to getting to the why. I want to end this by just asking one final question to you guys for our audience purpose. When you guys get that positive result, right? Because that's really where we want to try, and we want to prevent that positive result. But tell me from your perspective, when you get that positive result, right? I know that's one of the things that's your focus, right? We don't want to get there. That's where we want to be. We don't want to have to have that conversation with our patient. I'd like to hear from you guys as we close out our show, and for you to tell your audience, because I'm sure there's somebody out there that's listening to our show today and has come up for the reasons why they don't want to get that screening. Can you, Meagan and Jamie, what do you hear from your community, your patients, as to why they don't want to get the screening? And then how can they overcome that level of fear?
I have heard from patients, not just here, but in my entire career with anything that's of this magnitude, that patients would rather not know. They would rather not know if they, for example, had colon cancer, because then you think, well, okay, I have this, but then people automatically are going down the thought process with chemo and radiation and surgery. And so I think sometimes just preferring not to know is a preferred approach, because of the fear associated with what could come with that positive result. And I think that is that's a tough barrier to overcome. It is a tough barrier to overcome. I think what sets us apart here at the Community Health Center of the New River Valley is that we have the time to provide the education. We have the team to provide the education. We have behavioral health counselors who are able to vet concerns and meet with patients. We have an all hands on deck approach to, again, meet that patient where they are and provide that support for making the best decision for them. And so that is what I would want people to know, is that we have that ability. Sometimes in other practices, you don't have the luxury of having that large group of people to support you. You receive that information and you might talk to a nurse on the phone for a few minutes and that's it. But here we can do much more. And so with that fear that people do have, especially if they have significant risk factors, right? So if they have a parent or a sibling or someone else that's had colon cancer and they know that their risk is even higher, sometimes we might even see more resistance with that. So I hope people know that we can take a different approach, and that's what I would want people to take away from what we can offer.
Jamie?
The fear piece, Meagan nailed it. Tracy, was even a part of your question. It is coming from a place of fear 9 times out of 10. And so, my main message is that, when caught early, colorectal cancer is very treatable and very survivable, right? And so the earlier that we can, diagnose something early through a fecal test and then onto a colonoscopy. You alluded to it earlier, Tracy, with the actors who had polyps removed, right? Like a lot of times these can be taken care of during the typical screening procedure. And so I just really emphasize, like all screenings, if you're able to stay on top of those screenings and get them at the regular intervals, and those are different for different types of CRC screening tests, but in the long run, those fears around some of the complications and treatment options with cancer aren't even on the table, because you've been able to find it early. You've been able to remove the polyps or do some of those early interventions, and you don't even have to progress, down the road. And I'll just say one more thing, we've really been working on trying to put more positive narratives into our community around early detection, because so often the narratives that come out of our community in Southwest Virginia and beyond are not positive stories, and not stories that have a happy ending. And so we're really trying to shift some of that dialogue. And we know in our region that people react more to storytelling and hearing stories than maybe they react to risk in terms of numbers and percentages. And so, those are some of the things that we're thinking about as we're embarking on this project here for the next 3 years in terms of what we're doing at the patient level.
Well, ladies, that is real conversation. And that's why we wanted you on our show. So I want to just extend my gratitude on behalf of myself as well as our audience for agreeing to join us today and talk about colorectal cancer screening. And I hope that we can have you back at the end of your 3rd year and you can talk about your successes and maybe even have a patient or two come and speak with us about their experience. That I think would be really a good thing to have so that our audience can hear. So Meagan Arthur and Jamie Zoellner, thank you for your time and all the best to what you're doing. I know that you will make a difference in the community. I want to thank my guests for joining us today. And thank you to all the listeners for tuning in to Common Health, brought to you by the Virginia Community Healthcare Association. If you enjoyed this episode and you'd like to help support Common Health, I encourage you to hit the subscribe button, share it with others on social media, leave a rating and review, or visit our website at www.vcha.org. This is Tracy Douglas. Thanks again, and I'll see you next time.